With this, please allow me to introduce the world's most famous KOL in the blood purification industry, Professor Claudio Ronco. Professor Ronco is currently the leader director for the IRIS and the professor at the University of Padova, which almost has close to 1,000 years history of University of Padova, and he has published numerous publications. He is the pioneer in a lot of innovations. The term of the critical care nephrology by establishing the intensive mode of the multidisciplinary approach. His designing of a lot of therapeutic machine device. Also, he developed the first infant artificial kidney. He is the editorial for the purification, contribution to nephrology, and doing a lot of honors awards, including recognized as the top worldwide researcher for the kidney disease by Johns Hopkins University, and the most recently, last November, he received the Lifetime Achievement Award from the American Society of Nephrology. So let's give our warmest welcome to Professor Claudio Ronco to give the innovation.
So, good afternoon. I've been asked to cover this concept of innovation in AKI. AKI is a moving target, so every day we have new innovation and new information. That's why I decided to stop in the last 2 weeks when the new guidelines from KDIGO were published, so that we can somehow evaluate what are the situation. We knew already some years ago that this is a silent killer. And by doing a snapshot in the Lancet mission, we had recognized that AKI is common across continents and accounts for 20 to 30% of all hospitalizations. So it's a problem. And it's interesting that even our friends from cardiology have learned that AKI is dangerous, increased mortality, and increased length of stay. So there is a now common understanding that this is a problem. Of course, the incidence may be very different if you look into ICU or in cardiac surgery or in oncological departments, etc. But the most important aspect is that AKI incidence depends very much on how you define it. And there is an increased incidence of AKI due to comorbidities. We have more and more exposures. There is an increase of aging of the kidney because our population is aging, and we have iatrogenic interventions that lead to increased risk, increase in exposure, and increase in susceptibility. Now, what is the pathophysiology of AKI? AKI is a syndrome, and therefore there are several different cases. When we talk about ICU, one of the leading cases are sepsis and septic shock, and we're very much interested in that. But different types of surgeries are definitely important. And this describes a population that by demographics, by comorbidities, and by social environments have increased susceptibility, which means they are fragile, and the exposure, including acute illness, surgery, trauma, mechanical ventilation, different other aspects, including nephrotoxin, may contribute to the high incidence. Years ago, we founded a group of consensus called AKI that initiated a definition classification called RISO. And then from there, we moved to refining into AKI and finally KDIGO. And the common pathways of this definition classification is that when you move from risk, injury to failure of stage 1, 2, and 3, there is an increasing mortality, increase in hospital and ICU length of stay, increasing cost, and reduced renal recovery. Now, most of the diagnoses of AKI are made by increasing serum creatinine or reduced urine output. And so stage 1, 2, and 3 are defined by this. Stage 1 in particular is defined by a delta serum creatinine within 48 hours of 0.3 milligram per deciliter. But we know very little of what is happening before this increase in serum creatinine. And in reality, we know that in the process of moving from epithelium, which is normal, to a damaged epithelium, there are a series of candidate molecules that we can define by markers that may identify the process in a very early stage before necrosis, apoptosis, cell death, and decrease in GFR, and finally increasing cell creatinine occur. These biomarkers today may help to identify damage at the tissue level, dysfunction, reduction in glomerular filtration rate, like cystatin C, or stress, like Nephrology, which is a combination of T2 and IGF-7. So these allow us to build a continuum of AKI that goes from a normal kidney to a dead kidney, moving through different steps that go to increase risk, damage, dysfunction, and failure. So the 0.3 milligram per deciliter increase describe the difference between what we call clinical AKI from subclinical AKI, which is only identified by the increase in biomarkers and an increase in serum creatinine less than 0.3 milligrams per deciliter. Why is that important? Because we discovered that patients that have increasing biomarkers, even though creatinine does not reach stage 1 or 2, have the same outcomes as patients with concomitant AKI, which means that these patients are at risk for dialysis or increased mortality. We met in our university several years ago, making a recommendation for the use of biomarkers, and this allowed us to introduce the concept of the stage 1S, which is a stage in which only biomarkers are increased, even though serum creatinine is not being increased yet. Now, the new AKI-KDIGO guidelines now distinguish between functional criteria, which is basically increasing serum creatinine and reduction in urine volume, and structural criteria that are characterized by increase of damage biomarkers. So the stages now have been considered of different origin depending on functional or structural criteria, and damage biomarker alone may represent one stage identified. Also, in the definition, we have transient AKI versus persistent AKI when the duration is more than 48 hours. And also, in the functional criteria and structural criteria, we have the criteria to define AKD, which is acute kidney disease, when the insult and the dysfunction remains between 7 days and 3 months. So as you can see here, you move from a normal situation or chronic kidney disease into AKI, which may expand into AKD, and that's different functional outcome, going back to normal or progressing to CKD. And we have complete resolution, or we have partial resolution. And this is an important concept because here is the great burden of AKI. It is a doorway to chronic kidney disease. So this is a very important recognition. Now, why are all these definitions so important? One may say, who cares? But the important aspect is that these stages and these characteristic definitions may help to design clinical trials. And they are very useful because indeed, you know that in this table, you can move from non-AKI to damage, to dysfunction, both. But you can also, and this depends on risk modifiers such as inflammation, such as volume depletion, sepsis, etc. But you can also have a backwards modification when you apply mitigation intervention strategies like optimizing volume, correcting anemia, improving and controlling inflammation, etc. Now, this is somehow summarized by the so-called intervention strategies proposed by KDIGO, which basically are protective measures to avoid progression of AKI. And there are two studies. One is called PREMACI, the other study is called BIPAC-2, that have been made mostly by Alexander Zambok and his group, that show that when you apply a biomarker-guided intervention, you reduce the number of AKI and the number of severe AKI. And again, preventive care strategies significantly reduce the occurrence of moderate or severe AKI without increasing adverse event. So it is important because you can do something finally. We also did a study in Vicenza where we demonstrated that applying what we call the Nephrology Rapid Response Team, which is basically an immediate reaction of the nephrological team based on the positivity of biomarkers, we were able to reduce the number of cases of AKI, both in ICU and cardiac surgery, and the number of patients that required renal replacement therapy. So, having considered now the progression and the new aspects related to the timing of AKI that describe persistent or transient AKI, I think is extremely important to notice that within the first 7 days, we may describe different trajectories of the disease. And we have biomarkers that help us to discriminate between patients with persistent stage 3 and patients with non-persistent stage 3. Now, why is that important? Because persistent stage 3 increased 90-day mortality and increased major adverse kidney events. And as you can see here, from this slide, this biomarker called CCL14, which is a chemokine, practically overperformed compared to any other biomarker in predicting the persistence of AKI. And here you see that most patients with persistent AKI have a higher level of CCL14, and there is a difference in the different peptides to affect major adverse kidney events. There is another biomarker that is approved, is called DKOF3, DDK3, that describes the tendency to provide progression towards kidney failure and long-term loss of renal function. So, at the end of the story, you have biomarkers of different types, right? You have biomarkers that may be predicting and diagnostic at different timing and predict the trajectory of AKI. And the question is, why are they so scarcely used? And I think that there is a never-ending search for evidence, but we keep publishing papers, but there is always a request for more evidence. There is sometimes a guideline recommendation alibi not recommended in the past, but today they are in the guidelines. The cost creatinine is by far less expensive. And so the administrators of the hospital sometimes do not buy the biomarker. But also, there is a missing alliance between laboratory medicine and nephrology and intensive care, and sometimes scientific inertia. Too many lots of physicians that don't want to go towards an improved diagnosis process. So I mentioned before that progression to chronic kidney disease is one of the main aspects that is considered considering AKI as a very dangerous situation, right? So the point is that the progressive scarring and the production of cells that transform endothelium into mesenchymal cell and fibroblast is due to maladaptive repair. And the maladaptive repair consists in a G2 cell cycle arrest with endothelial to mesenchymal transition of cells in the kidney tissue. There are molecules that affect, including complement, including other molecules that may represent a target for our hemoadsorption therapy. Why? Because patient with AKI has 8 times 0.8 the risk to develop chronic kidney disease and 3.1 times risk to develop dialysis. Now, if you have only partial recovery instead of complete recovery, you have a kidney which is more prone to receive other insults or to respond with AKI to subsequent insult, moving towards progression of the CKD. What we have learned today is that these patients may have lost partial their renal functional reserve. In other words, some damage has occurred, but before you can see a rise in serum creatinine, you must have lost more than 50% of the renal tissue. So there is no question that chronic kidney disease starts here, but you can only diagnose by a change in baseline GFR. Now, we have done an interesting study in Vicenza, London, and Gießen, where we basically measured the renal functional reserve before elective cardiac surgery. And what we found was that patients who developed AKI had a lower renal functional reserve. But the most interesting aspect is that those patients who have normal renal functional reserve and develop AKI during or after cardiac surgery, 3 months later present a reduction in renal functional reserve. This is extremely important because in the process of recovery, you may see this important aspect. You may have full recovery when you go back to baseline GFR and you have impact renal functional reserve. But you have an apparent full recovery when you have a baseline GFR, which is normal, but you have a reduced renal functional reserve. This kidney is at risk of other results of AKI. What about renal replacement therapy indications? In the past, guidelines have used the term you apply renal replacement therapy when it is needed, which was obvious, of course. Now, we move from this concept of balance between demand and capacity of the organ, and when we have a gap in this demand capacity ratio, there are indications which may be urgent or may be relative. And this was already published several years ago in the book of Nephrology that Rinaldo Bellomo and myself have presented. When to start and when to stop? This is a very frequently asked question, and recent studies have somehow led guidelines to recommend a strategy to slow down and defer the initiation of renal replacement therapy unless there are urgent or immediate indications. But one of the important aspects is that the guidelines underline the fact that every patient is different and every patient has to be evaluated. So today in many centers there are specific RT initiation algorithms that in part are supported by artificial intelligence. I honestly still prefer the human intelligence and prefer to discuss with the intensivist for each case and each patient. There is no question, however, that technology today assists us in the risk assessment with biomarker, in the clinical diagnosis, and we can also have electronic alerts from electronic medical records, indications, relative, absolute, or non-renal, and then identification of therapy targets in terms of defining what the prescription is, dose, volume, homeostasis, organ support. And then, once you prescribe the therapy, you have to define the technique, the machine, the dose, the settings, anticoagulation, and possibly you deliver exactly what you prescribe and monitor, and in case you have to be ready to modify the prescription if the results are not somehow acceptable. So basically, in terms of dose, today we recommend the use of 20-25 milliliters per kilogram per hour, but as you can see here, what is suggested is a dynamic prescription. And in patients with sepsis or with severe catabolism, most of the cases you end up with the 30 milliliters per kilogram per hour, which was our original indication in the paper we published in Lancet already in the year 2000. The other thing is that we're not looking at the picture, we are looking at the movie. So in every patient you have continuously to monitor the situation of the metabolic control. Data may be provided by the lab, from the patient, from the machine, may be elaborated in the computer, and may lead to an automatic biofeedback. Many machines today are able actually to assist with dynamic prescription depending on the possibility to reach physiological targets. For example, the difference between dose delivered and dose prescription may modify the parameters of operation of the machine based on this concept. Now, most of you are intensivists and know very well that there are systemic effects of AKI. There are several different organ crosstalks, and patients who present more than one organ failing have higher chance for mortality. For this reason, we consider today not anymore a renal replacement therapy, but rather a multiple organ support therapy, which may include the therapy for AKI and sepsis, liver failure, lung dysfunction with removal of CO2, and heart failure and fluid overload. This is the evolution of machines and treatments over 40 years of CRRT. I have this picture because most of these machines have been designed in our center, have been tested in our center, including the very latest machines for hemoadsorption. Now, one of the issues that are important is we need to speak the same language. We need to make clear that there is a nomenclature, and we have developed a nomenclature standardization initiative alliance with companies and with academics in order to define the treatment with the right names, and we published in Blood Purification the nomenclature papers for acute, chronic, and non-renal indications. What we know today that, especially in patients with sepsis, there is a tremendous organ crosstalk with cardiorenal syndrome, hepatorenal syndromes, pulmonary dysfunction in presence of AKI, etc. And at this point, we know that we move to extracorporeal organ support, which is based on simple modification of the extracorporeal circuit to support more in one organ. So we can actually support the kidney, we can support the heart, we can support the liver and the lungs, and we can also provide therapy for sepsis. The problem of organ crosstalk is important because once you have one organ failing, other organs may respond at the systemic level, at the organ level, at the tissue level, at the cellular level. And so we have, for example, cardiorenal syndrome, lung kidney dysfunction with interaction, hepatorenal syndrome, and sepsis that affect kidney function. But at the same time, different organ support systems may affect kidney function and cause AKI. And in some cases, the same organ support therapies may affect the function of our dialysis and renal replacement. So this is also the case when we use ECMO, for example, and CRRT, or when we use hemoadsorption in conjunction with ECMO. And we know that basically extracorporeal life support may represent a complication for the kidney, and patients who receive different level of support may have increased risk and observation to develop AKI, to require renal replacement therapy, and to have high mortality. So we have to learn how to deal not only with the organ crosstalk, but also the artificial organ crosstalk. That's why our technological approaches should be integrated and should be able to teach us how to better perform our therapies. Another aspect is there a molecular signature for different types of AKI? We had this Cappuccino in Asiago, which is a mountain town near Vicenza, where we basically established that it's now time to move towards molecular diagnosis and especially endotyping of patients. What does it mean? It means that precision and personalized medicine should be utilized for population enrichment trials. If you do trial on hemoadsorption in sepsis, you may have positive, negative, neutral effect, but if you select a specific population, you have higher chance to find the positive results. So that's why, from the most pragmatic, less invasive intervention, low-cost intervention, which was not generalizable, we have to move to most exploratory, enriched population, which has high generalizability. And once you identify AKI for severity, duration, trajectory, and you identify sepsis for comorbidities, variable, laboratory measurement, genetics, etc., you can actually end up with different specific phenotypes that may or may not require therapy, but a specific therapy may be suggested by artificial intelligence and machine learning systems. And in fact, in the sepsis-associated AKI consensus conference, we strongly advocated the identification of specific endotypes in sepsis in order to enrich clinical findings. Now, here you see that you may have different endotypes that are characterized by very different characteristics in terms of biomarkers, specific molecules, etc. And this means that the different therapy may have a different effect in different patients. So today, for sepsis, 4 different endotypes are mostly identified. You can consider ischemic topic AKI, cardiorenal syndrome, hepatorenal syndrome, sepsis-associated AKI in started with. And there are CRRT, extracorporeal C2 removal, plasma filtration adsorption, DPMAS, which is a system for liver support, hemoadsorption plus CRRT, or hemoadsorption alone. Now, hemoadsorption has been object of the consensus conference a couple of years ago, and we reached publication in NDT and CJs, and also we published this book in Contribution to Nephrology. For example, for liver dysfunction, it was made clear that now the MAS are being discontinued. DPMAS and plasma filtration adsorption represent the only possibility to achieve adequate liver support with the next therapy in compensated cirrhosis. And the system is quite simple because basically once you plasma separate from blood, we circulate plasma through two different cartridges with two different characteristics in terms of removal of bilirubin and inflammatory lipids. And this is the capacity of bilirubin removal that has been studied in our laboratory. You see how much we could remove from concentrations which are almost 10 times what you see in clinical practice. Basically, the other aspect is to enrich the trials for specific population, because so far studies with pharmacological approaches in sepsis have been failed. Now, if we consider sepsis as an initial status of infection that leads to triggers such as cramps and dumps, and finally sensors that develop the pattern recognition receptors and reaction of the immune system, you immediately see that when you have any toxin, for example, it has been demonstrated that you can have a positive outcome if you apply a selective removal of the toxin. And Tigris has been recently published. However, the immunological arrangement of sepsis is far more complex than simple toxin. Here you see, for example, that in the early phase, viral infection, bacterial infection, CAR-T therapy, hemophagocytic syndrome may trigger activation of innate immunity, and patients tend to die due to intractable inflammation. But then at the same time, there is activation of adaptive immunity, and some patients tend to die for immunoparalysis. So what to do in this case? Well, we know that our recent solvents are capable of removing both pro and anti-inflammatory mediators. And even the most recent solvent called CA resin is capable of removing cytokine plus LPS and the toxin. So the point is the peak concentration suggests that because we cannot measure immediately cytokine levels and effects, we can actually use non-selective adsorption, and you will remove more of the substance that has higher concentration in blood, somehow constituting a kind of homeostasis or immune homeostasis. And indeed, this is what we find in general with reduction of cytokines, but the most important aspect that we observe is the biological effect on endothelial protection and prevention of organ damage. So, not only will you immediately see when you apply hemoadsorption reduction of vasopressor support, improvement in blood pressure, reduction of circulating cytokines, but you see a biological signal, especially in the capacity of the monocyte to respond again, and in particular to express on the surface HLA-DR, which is the way monocytes present the antigen to the immune system. So it is important to consider when you do now trials, what happens in the situation of the patient. This is a patient, for example, during COVID, admitted with a hyperinflammatory syndrome that was treated for 3 days with session of hemoadsorption for 6 hours each day, and led to a stabilization of hemodynamics, decreased inflammatory parameters, and improved hormonal exchange until restoration. Again, once you have identified the different endotypes based on metabolites, protein signature, cellular function, means profile, you may at this point reach the population you are going to study and decide which patient should receive which type of therapy. In our approach, we use what we call sequential. In other words, you may need in the very early phase a system that removes a pathogen, endotoxin, and cytokines because you want to prevent progression of the AKI and organ damage. While subsequently, when immunodysregulation occurs, you may need to remove cytokines, spams, and dumps before you start replacing training organs. But you have to be aware that these cartridges saturate almost 90% within probably 6 hours. So it makes no sense to use them for 24 hours. You have to use it for short treatments, and our suggestion is actually to use it for repeated sessions. So maybe the first day of sepsis, you can use 2 sessions of 4 to 6 hours, and next days you may have another session. This is what we call the 1-1-1 or 2-1-1 sequence of. How do you design a trial? First of all, you make clear indication criteria, select the population, identify the subphenotype, define the target, and then you understand that you may have biochemical endpoints, biological endpoints, cellular and tissue effects, vascular effects, physiological and clinical endpoints, and only at the end you may start studying mortality, which may be affected by many other endpoints. So this is what we do normally. When you have AKI, we try to phenotype and finally endotype and see 2 particular endotypes. One is a patient that has a hyperinflammatory profile going to sepsis that may require 1 to 3 6-hour sessions. The other is a patient that has stage 1 AKI in a sepsis situation. Let me show you what happened in this patient. There is late or no creatinine increase, blood flow is increased, GFR decrease, urine output decrease. There is a cytokine-induced vasoplasia that induces polyuria. Now, in this case, basically, you have polyuria which is determined by the cytokine release syndrome, and there is no damage yet in the kidney. This is the continuum of AKI in sepsis. Now, at this point, since this is suspected to be caused by a release of cytokine, this represents the target of therapy. So if you apply right here the early phase of your hemoadsorption, you have the chance to return to a lower level of severity. More data acquisition can be achieved today thanks to the wireless or cloud storage, and it is important to know that automatic data collection allows us to have a large number of information. That's why we can do pragmatic trials, and that's why we can apply the so-called quality approach, which is basically policy planning, procedure definition, protocol enforcement, and error analysis, and start modifying planning again. Now, the number of data that are available today is enormous, and the increase in data requires a careful analysis on how you make your decision. Basically, big data should be analyzed in terms of epidemiology, correlation, evidence, and decisions are part of healthcare policies and strategic planning. At this point, if you have somehow a very, very small deviation from the final target, you may control the outcomes. But if you have large deviation from your target, you have to change the course. This is helped by artificial intelligence at the different 3 levels: intelligence, machine learning, and deep learning that allow us to do what we call clinical trials. In other words, trials where models and correlation are achieved independently from the human input in the system. And machine learning automatically adapts the minimum human interface, and deep learning is a subset of machine learning using neural networks to mimic process of human brain. Now, be careful, because this system has different possibilities. As you can see here, you can use it for different implementation of trial and programs, etc., training. But this system that today is including the transformation of language, in other words, the use of so-called ChatGPT or other systems that include generative artificial intelligence, may lead to models that indeed present different possibilities to predict new approaches to instruct and prompt to a specific task, to tune dialogue, finally. But be careful, because this system suffers from hallucination. Sometimes, to please you, they tell you bullshit. They tell you not real things, and you have to control, because this is called the dark side of technology, where quality of data may be questionable, and one size seems to fit all. And sometimes, especially young fellows, use artificial intelligence as a substitute of human intelligence, which is not what it is intended to be. What about the future of CRRT and ECOS? Well, patient endotyping, we have described, optimization with integration of different modalities and AI-driven technology, patient-centered care and precision protocols, and new membrane, possibly new sorbents. We have seen the big capacity of this company to develop different sorbents. I know that they are already thinking about functionalized, non-thrombogenic surfaces, new specific solvents, etc. And in the future, also miniaturized devices, robotics, possibly drink protocols as well. AKI recommends the use of precision medicine. Timing of initiation can be variable depending on capacity and demand, and criteria for stopping are not clearly defined. Biomarker may help. More dose is better until a certain point, but dynamic prescription is probably the best approach. Different modalities are available, and new technological advances, including AI, should help clinicians to optimize patient handling. Of course, when you speak about this, there are two important aspects that should be considered. One is increased investments. This is a problem because you have no results without increasing investment. The other is multidisciplinary collaboration. And you may know that I actually invented the term critical care nephrology. In Vicenza, we developed a model of collaboration that was a strict interaction between intensive care and nephrology. AKI conferences have helped in setting the stage for topics where guidelines were not already covering these aspects, including, for example, the recent implementation science or the interface between extracorporeal lung support, ECMO, and CRRT, and finally persistent AKI. In June in Vicenza, after the Vicenza course, we're going to have an AKI on fluid management. Now, last words about the so-called pyramid of evidence. We all know that systematic review, meta-analysis, and randomized controlled trials represent the dream of the passionate people about evidence. But in most of the cases, what we are dealing with is case series reports or individual case reports. And there is nothing that substitutes our personal experience. Now, it's interesting that finally they have written in the KD what I recommended for many years, which is this sentence. Guidelines are not intended to define a standard of care and should not be interpreted as prescribing an exclusive course of management. Healthcare professionals using this recommendation should decide how to apply them to their own clinical practice, which means an important aspect. In many cases, our administrators say, "Oh, I'm not going to buy this cartridge because there is not enough evidence." Look at your guidelines. They do not recommend. There is a difference between we do not recommend, which means we cannot recommend this for everybody because we have no enough evidence, etc., from we recommend not to. This is a recommendation of not doing something. The other is, I'm sorry, we cannot force you to do that, but you should be responsible of your choices. And we are going to discuss many of these aspects in the 44th edition of the Vicenza course in June in Vicenza, and you're all invited to come and join us. Thank you very much.